So let me start my presentation with a tale of two subtly similar scenarios. Case number one was a 45-year-old lady who presented with left eye defective vision since 3 months. It was painless, progressive, associated with colored halos. There was no history of floaters or flashes of light, no history of trauma, no history of fever, loss of weight, loss of appetite. There was no history of breathlessness or hemoptysis, no history of altered bowel habits, no history of oral or genital ulcers. The patient had the best corrected vision in the right eye of 6 by 6, in left eye it was 6 by 24. The anterior segment was appearing within normal limits. Whereas the left eye showed subtle looking non-granulomatous to granulomatous keratic precipitates, and they were medium size, diffuse more in the center. The left eye intraocular pressure was elevated to 32 millimeters of mercury. Gonioscopy was meticulously done and it showed 10-shaped peripheral anterior synechiae as documented in the picture. The fundus examination of both eye was within normal limits. The working diagnosis reached was left eye chronic granulomatous anterior uveitis with secondary intraocular pressure rise. At this scenario, what are the list of differential diagnoses which you would like to entertain? I would like the audience to type in their answers.
Bala, first, one of our viewers has said viral uveitis.
Yes, sir. It is a wonderful guess. In fact, it is correct, and it is quite possible.
What are all the features for and against viral uveitis, Bala?
Yes, sir. The points for viral uveitis is uveitis associated with raised intraocular pressure rise. We had a granulomatous type of keratic precipitates, and along with few micro granulomatous or non-granulomatous, which can very well happen in viral uveitis. And all these pointers are very strongly towards viral. There could be other differentials in addition to viral uveitis, sir. The points against viral could be the gonioscopic finding of peripheral anterior synechiae, which could point towards this very chronic systemic pathology.
And our another group has Aishwarya has said it probably can be a Fuchs uveitis. You want to agree or disagree, Bala? Fuchs uveitis?
Yes, sir. In fact, I will do both. Partly agree, partly disagree. 85% of Fuchs uveitis is non-granulomatous. Only 15% is granulomatous. The fact that here it is there is granulomatous KP makes me to think Fuchs at the back seat. However, atypical Fuchs in the 15% would present like this, sir.
So we had a differential diagnosis just for our viewers. It was a unilateral case, non-granulomatous to granulomatous KPs, and also he was talking about this tenting PAS and an increased IOP. Bala, a lot of at least 3 or 4 participants are saying it could be sarcoid.
Yes, sir. That is a fabulous answer, sir. In fact, that I will put it as a first differential diagnosis because there is a closer differential of Fuchs uveitis, which traditional mindset could think of. There is a peripheral anterior synechiae, chronic uveitis because of recurrent inflammation has caused adhesion as peripheral anterior synechiae, causing a rise intraocular pressure rise, along with granulomatous keratic precipitates very well fits into this fabulous guise of sarcoidosis, which I really appreciated.